Okay, welcome back, folks. We're continuing our discussion this morning on an act relating to the Rare Disease Advisory Council, and we have Danielle. I'm going to have you pronounce your last name for us, and we have Karen Hammer Williamson.
Spatafora.
Say it again.
Spatafora. Thank you for asking.
Spatafora. Okay, great. Welcome. So we, as you know, we're considering whether to establish a rare disease advisory council here in the state. And we've had some testimony this morning from the health department who says, thanks, we'd love to participate, but we don't think we can take it on. And we certainly have had some testimony from individuals who themselves or their family members are impacted by rare diseases. And so we appreciate you both being here to talk about the impact of ALS and what this Rare Disease Advisory Council would have here in the state. So I'm not sure who wants to go first.
I'm happy to go first, if that's okay with you.
Okay, that'd be great. Thank you, Danielle. The floor is yours.
Thank you all so much for your time this morning and for this opportunity. So I am here to speak in support of H46. Again, my name is Danielle Spatafora. I'm the Managing Director of Advocacy for the ALS Association. And on behalf of the association, and we serve about roughly 50 families in Vermont currently, we do want to urge you to swiftly move this through your committee. So this would establish a Rare Disease Advisory Council, as you all know, and that would help give a voice to the estimated 1 in 10 individuals that are living with a rare disease in Vermont. So technically, any condition that affects fewer than 200,000 Americans is considered to be rare. And so though it's well known as Lou Gehrig's disease, and it's received a lot of attention from the Ice Bucket Challenge, ALS is actually still considered to be a rare disease. If you're not familiar with ALS, it's a fatal progressive neurodegenerative disease, and it solely robs a person's ability to walk, talk, eat, and eventually breathe. There is currently no cure for ALS, and there's no significantly effective treatment option for a person with ALS. Like many other rare diseases, ALS patients face very unique challenges every day, from obtaining an accurate diagnosis in the beginning to accessing medical specialists with knowledge of their condition and battling for fair insurance coverage for treatment and care, especially in a rural state like Vermont. Due to these small patient populations and the very large variety of rare diseases that differ, it can be difficult for state governments to have an in-depth understanding of the rare disease community's needs. And this lack of awareness contributes to the obstacles that they face every day. Creating a Rare Disease Advisory Council in New York will not only raise awareness and give rare disease...
Or Vermont.
Excuse me?
You said New York.
Oh, I'm sorry. Did I say New York? I'm already looking at my paper and it says Vermont. We are doing it in New York as well, so my apologies. This is going to give a unified voice to Vermont state government. And to my point, this is going to join 29 other states that have already enacted similar legislation. That would include New York and Rhode Island. That would become kind of the final of the Northeast area of the country that would have this type of council. So this step, in our opinion, would really demonstrate that Vermont prioritizes people living with ALS and other rare diseases, regardless of the size of the population. And we really want to bring a voice to the Vermonters that are living with a rare disease. So again, on behalf of the ALS Association, all the patients we serve, we thank you for your consideration of the issue. And we hope that we're able to create a Rare Disease Advisory Council.
Thank you, Danielle. I'm just curious if either one of you have seen the report posted on our in our reports page on a few years back, not too long ago, 2022's legislation. So I think they started collecting data in 23 in terms of the ALS registry. So it's some interesting initial. It's our first report. It's an interesting initial information on ALS and noting the number of new diagnoses in the state last year was 27, which seemed high to the person from the health department reporting, but it's too early because we don't have trends associated with that yet. But it's I guess I would say that that was something that we instituted. Again, the health department was not in favor of that, even though we did have people willing to pay for it at the time. So I think that it would be helpful to hear from you. We can see that we're kind of an outlier. We've seen the map that NORD has, and just interesting to understand, what do you see as the benefits of a rare disease advisory council, sort of state by state, and then how do you see that on a national basis impacting the diagnosis, the screening, the services, the treatment, all of that kind of thing?
Yeah, all great questions. And we so appreciate the creation of the registry. That's been wonderful. And there aren't many of them across the state. So we definitely commend Vermont for doing that. And to your point, there are new diagnoses coming every year. We are seeing prevalence rise just a little bit every year. The interesting thing about ALS is that every diagnosis is very unique. So even though those numbers rise, no two ALS patients are going to be the same. They present very differently. Their prognosis is very different, and their symptoms can be very different. And so that time to diagnosis can still be 9 to 12 months. The lack of clinicians that are, able to really recognize someone living with ALS from the beginning is still very low. And so connecting our patients, even though that number begins to rise, to qualified folks and giving them the information that they need is still a struggle. From my perspective, I do cover a wide kind of territory of states that do have rare disease advisory councils. And I think at the very least, it's a really great opportunity to bring together this community and give them an outlet to be able to discuss the things with members of government that they're struggling with. And it allows them that platform to share what's going on that they otherwise wouldn't have. Excuse me. And from there, the members who participate, and it's very wide, as you can see in the bill of kind of what we recommend as who is a participant, but we're able to see clinicians, caregivers, patients sharing this information with members of government, and then that can influence policy going forward. So we've seen a lot of benefits, and I think especially in a state like Vermont, where needs are going to be very unique because of the state that it is. Those people need that platform and that voice. And Karen can speak a lot more to specifically how this impacts our patients as our manager of care services. So happy to let her jump in as well.
Great, thank you. Okay, Karen, let's hear from your thoughts.
Sure. Thank you again for having me. For folks who weren't here the last time recently, I'm Karen Hammer Williamson. I'm a social worker. I serve in the ALS Association Care Services program covering Vermont and the 3 counties of New York State that send to UVM ALS Multidisciplinary Clinic. I cover Vermonters regardless of where they access any specialty care for ALS. So I see about 90% of Vermonters living with ALS. Prior to that, I served as the first residential alternatives unit supervisor for the Vermont Department of Dale, working closely at various times with the Department of Health to help promote independent living programs and supportive services coordinated with housing as an alternative to nursing home, and expanding. I was part of the team that expanded the waiver to choices for care. So I deeply respect the Department of Health's workload, especially in this time. But when I look at its mission to promote the physical, mental, and social well-being of people in Vermont by advancing equity, protecting against disease and injury, and preparing for health emergencies, my question is, why haven't we had an RDAC? When you look at these different groups, there are so many of them. They are often high-cost disabilities and conditions to live with, and there are so many of them to communicate with or assure public health communication with them that it seems to me that it would make life easier to have an RDEC than to live without it. some examples. Recently, changes were made in access to medical transportation without notice to many of the rare disease groups that limited access for appointments, both for specialized care across counties and preventative care. Because if you have certain medical conditions or need to use a power wheelchair or wheelchair transportation, your choice of providers may be limited, and you may need specialized transportation to access those services. And so that's just one example of the way that equity becomes an issue in accessing preventive care. And so many of the Department of Health's goals for Vermonters depend on accessing both specialized and preventative care. For instance, I hold one of only 2 support groups nationwide for individuals living with bulbar ALS condition. That's the form of ALS where respiratory, swallowing, breathing, and speaking are first affected instead of changes in limb function. One of the key treatments for preventing and reducing incidence of pneumonia is more frequent preventive dental care. Yet people may need, again, specialized dentistry, accessible chair dentists, and without transportation and coordination and being able to get those additional appointments, it can be difficult to access that care. Sometimes people have to choose between going to their preventive care or their specialty care, yet they're designed to go in concert. Those needs need to be highlighted in reports that would come out of an RDAC and that would set on agendas with the different collaborations in Vermont so that the needs of these patients are not overlooked or put into competition with Vermonters who don't live with complex needs. Another area has been in the area of emergency preparedness. It's long been identified that people with high-level disabilities and complex needs are at greater risk in natural disaster, in evacuation from fire, and other public emergencies. We do a program of issuing red cards that try to alert 911 providers to certain ways that care in the field should and should not be performed, and also promote ALS files of life. But it's very difficult to kind of coordinate with the whole of Vermont emergency management, and the Department of Health plays a key role in coordinating those kinds of responses across departments of state government. Doing that as a coordinated rare disease initiative would assure that we are feeding in collectively to ways that work for rural emergency management and make it easier for them to successfully manage the divergence of information that's available about who needs what type of emergency care. In terms of your comment about the rise in diagnoses, we don't have all the data yet or even a way to know, but one component of the increase, we know that incidence and diagnosis is increasing with awareness. Vermont also is in an unusual position for now of having medical aid in dying. And a small number of those cases will be people who came to Vermont for medical aid in dying, had to be diagnosed by a primary care provider in order to access that care. And so they would have been reported into the registry, even though they may have long had ALS. But that certainly does not explain the entirety of the increase, in my view. More to come as all the researchers and the docs look at the data and weigh in. Our ability to quantify that is also limited by the privacy protections around medical aid in dying. Finally, I think for the Vermont Department of Health, again, it could be a long-term efficiency, although there's some startup. There are certainly many of us in the field who struggle to access and maintain information, and we would be willing to help the RDAC and the designated Vermont Department of Health staff with that initial lift to get an RDAC going. Thank you so much.
Thank you, Karen. What are your thoughts about the suggestion that perhaps the UVM Medical School host the RDAC?
I think that would be fine if they had the capacity. They also have the Vermont AHEC that has been a key partner with the Department of Health, so that could be a point of coordination. And I think also working with, I think anybody that is regularly has the capacity to coordinate, as long as the Department of Health was committed to following the work and to coordinating with its unique resources as indicated. But the absence of these groups from state plans is remarkable and unfortunate given the Department of Health's stated mission around equity, reducing harms, and promoting emergency preparedness. So there needs to be some kind of commitment from the Department of Health to better address the entirety of all these diverse groups.
Mm-hmm. Thank you. Other questions for Karen this morning? Okay. Thank you both very much. And if you have any particular suggestions on components of the bill, like who should be on the RDAC, et cetera, we were noting earlier that perhaps a representative from Dale should be on the RDAC,
Yes.
given the supportive services as people grow older, and for people with developmental disabilities, that seems like that would be a important organization to have there. So
I completely agree with that, Teresa, and it would not be without precedent given that they have had an Alzheimer's group. The advantage of the RDAC is that it would be an umbrella for so many. Again, I think that could simplify public officials' lives considerably.
Mm-hmm. Thank you. Although I don't think that the other specialty groups will want to be giving up their own status. As I see Representative Noyes shaking his head. And so, all right. I don't see any other questions this morning. Thank you both for being here. We really appreciate your focus on ALS and how that pertains to the bill that we're taking up, and what you do for, people, particularly you, Karen, what you do for people in the state that helps them, through this disease, and their caregivers.
Thank you so much. And thank you for all the work you've been doing. My caseload does include people who, believe it or not, are facing homelessness and ALS at the same time.
Yeah.
I appreciate everything that you've been dealing with this session.
Thank you. I appreciate that. Yeah. I can't imagine having ALS and being homeless at the same time.
Yeah.
So I'm going to make note of that, because we may need to use that piece of information. Okay. Thank you, Karen. Appreciate it.
Thanks.
Everyone.
All righty. Okay, folks, we have at 11:30, do we know if Katie's coming back or not?
She is booked.
Okay. In other places. Okay. So let us just go offline for a few minutes till 11:15. We'll come back, and I'm going to, and then we'll be voting on S